Antibody-drug conjugates, or ADCs, have transformed cancer care, but with these advances come different challenges in symptom management and supportive care. One of the most common symptoms is nausea and vomiting. Without preventive strategies, nausea and vomiting may be experienced by many patients receiving ADCs. And for patients, these symptoms can drain quality of life and make it harder to stay on treatment. ADC dose reductions, treatment delays, or treatment discontinuations may decrease the clinical benefit of ADCs. The good news is that we have a number of very effective strategies to mitigate this toxicity. With ADCs, nausea can persist well beyond the first day of treatment. That is why prophylaxis needs to start before the ADC infusion to cover the acute phase and continue into the delayed phase during the first 2 to 4 days after the infusion. Some ADCs have been associated with long-delayed nausea, lasting up to 1 week after the infusion. The goal is to prevent symptoms before they start, because once nausea begins, rescue treatment can be more difficult and may be less effective. Guidelines reinforce the need for acute and delayed prophylaxis, as well as rescue strategies for nausea that escapes prophylaxis. Both MASCC, ESMO, and NCCN antiemetic guidelines classify several approved ADCs in the highest emetogenic risk category. They use different terminology. MASCC and ESMO guidelines label them as moderate emetic risk agents, and NCCN as high emetic risk agents, but the underlying message remains the same. On day 1, the standard approach is triple prophylaxis with an NK1 receptor antagonist, a 5-HT3 receptor antagonist, and dexamethasone. In some cases, low-dose olanzapine may also be added. For the days that follow, MASCC and ESMO guidelines recommend tailoring prophylaxis and rescue medications to individual patient factors. NCCN recommends continuing agents such as a 5-HT3 receptor antagonist, olanzapine, dexamethasone, and an NK1 receptor antagonist when indicated. Prochlorperazine and lorazepam are also used as part of the rescue strategy. Beyond prophylaxis, simple measures such as a balanced diet, smaller, more frequent meals, hydration, and rest can also help manage nausea and vomiting. If nausea persists or makes it hard to eat, drink, or take medications, patients should contact their healthcare team. Highlighting these strategies helps clinicians and patients work together. When symptoms are reported early, care teams can adjust treatment plans in time, protecting quality of life and avoiding dose reductions or interruptions. Prophylaxis can be adjusted for subsequent cycles depending on symptoms, and side effects from prophylaxis and rescue strategies should be discussed and managed proactively. With ADC therapy, prevention of nausea and vomiting is the most effective strategy. These can be very effective drugs, and we can work together to manage side effects, optimizing quality of life, as well as anti-tumor efficacy. Thank you so much for listening.